off and John. Thanks.
All righty. Very good. Well, thank you, Thank you, Sarah. Welcome, everyone. Some of you may be aware that this is the last meeting of this august group. And we will have some time later in the meeting to reflect on the work that we've done and to acknowledge each other. And for me and others, Kevin and others, to thank everybody for just the wonderful effort that we have been under. And so we will have time on that. Because we are in a short week, hopefully people are not working on Thursday at least and Friday. We're going to try to also make this a slightly shorter meeting. Some of you know we were scheduled to go till 4 o'clock, but in fact, we're going to go till 3 o'clock, and we will have you out by 3. With that, I want to just say welcome and lovely to see everybody. I can't see everybody yet, but we will. And Sarah, should we do a roll call and make sure so we know who's here?
We can do that.
All right. You want to lead us in that work, please?
Sure. Jack Friedman, you are present.
I am.
Kevin.
Present.
Pat Allen can't join us today, so Craig.
Here.
Catherine.
Here.
Angela. Not here. Okay. Bill Ely also has a conflict and can't join today. Jessica. Mary Beth.
Here.
Felisa.
Here.
Jason.
Here.
Brian. Brian, I thought I saw your phone line come on. Maybe not.
Maybe he's on mute.
Maybe he's on mute. John.
Present.
Mark is not here. William. Ken.
I'm here.
Shannon.
Here.
Scott. Scott and Andrew.
Hey, good afternoon.
Great, so that's everyone.
Okay, welcome to all. Thank you for being here again. Have you had a chance to review the October minutes? And can I just ask if there are any questions or clarifications? We don't need to approve these, I don't believe. But I do want to make sure there are no errors or concerns about them. Anybody have anything to add to the October minutes? Okay, hearing nothing, we will informally approve those, Sarah, and move on. Can you put up the next slide so we can see the agenda? Okay. Oh, okay. We'll do it that way instead. I guess. All right. Do you have a picture of the agenda that we can look at, or are you choosing just to mess with my head?
The agenda will be up in a second. Hold, please.
Okay. Okay.
And it looks like we got Angela and also Brian, I think, have joined us.
Okay, good. Great.
Hello.
Hello, everyone. Welcome. Okay. I suppose I could do the agenda by what I have here, but it's always good to do. Oh, there we go. All right. So today we're going to spend time hearing from Jeremy and Sarah, although Jeremy is going to be a little late to join us. So Sarah will cover most of this first agenda item, which is basically to just take a look at the work that's underway, particularly giving an update on the value-based payment reform work and just kind of general status updates and give an overview of our 22 work plan, much of which will be outside of the purview of this group because we're going away. But it's important that you understand what the goals are for next year. After that, we will ask Michael. Balin is with us. We're thrilled to have you, Michael, always. And he's going to provide an overview of the work that's been underway in the rest of the country. As you know, there are another 4 or 5 states that have similar efforts underway, and he's going to give us an update on that and maybe tell us how Oregon has been a little different than the rest of the country. So that's always good to know. And then we will, share thoughts about that. And we'll also have a chance to just talk a little bit about how this last couple of years has gone, and to acknowledge the work that we've done, and to give any advice that we want to share with the Oregon Health Authority, which will be responsible for implementing this work, along with the new advisory committee that will be coming together next year. So I suspect that Sarah will give us some dialogue about that, and Jeremy would be my guess. And then we have our public comment at the end. And again, the goal is to try to get everybody out by 3 o'clock. Did I miss anything, Sarah? Probably.
Nope, you got
Okay.
everything.
We got everything. Good. Oh, that's a first. Okay. So Sarah, you wanna take us through the implementation updates, please?
Yes, and I'll start, but Gerondi, can you switch back to the slides and pull up slide 6, please? Thank you. Okay, so we wanted to just give everyone a status update on a whole bunch of things that are moving for the program. As you all know, we've been working to implement your recommendations, and there are lots of moving parts. So going to touch on a couple of the big pieces of that right now, starting with the initial data submission. So last month we shared that the initial data submission was due October 1st. We were expecting to receive 34 submissions, 34 files from carriers, both domestic and national. And as of November 12th, we have received 26 of those 34 submissions. So 8 are still expected, and we are in contact with all of those data submitters. We've granted extensions to ensure time for the completeness and the accuracy of that data. Again, I think we shared this in October. We thought it was worth the extra time on the front end to make sure that those submissions are as complete as possible before they send in. So we are expecting the rest of those over the next couple of weeks. Of the 26 submissions that we received, 12 are pending resubmission for data issues or questions that have been identified. So we are working on continuing to validate that data and review that data. And that process will carry on likely into January. Next slide, please. So, sorry, guys, I don't know why we are losing the slides every time we transition, but next slide. Just to touch on our data reports, we are continuing to work on both our standard analysis to monitor cost growth relative to the cost growth target, and those in-depth analyses of potential drivers of high cost growth and variation, and cost variation. We talked about that a little bit at the last meeting when we previewed some data. We are going to continue to work on that. I wanted to provide a little more detail.
He gets in a position to be able to do it, but yeah, it seems like you said something.
Folks, if you're not speaking, could we ask you to please go on mute, because we're hearing some background noise. Thank you.
Yeah, and Michelle and Gerondi, can I ask you to switch who's sharing, because this is not, we're not quite on the ball here technically today. Okay, so for some data reports in progress. So last month we shared those historic cost trends, 2013 to 2019 data. You had a lot of questions. We are continuing to dig into that data. We have identified some issues and are continuing to work on it. So that is in progress, and we will likely have an update hopefully in the next couple months on that. We are also starting to work on a data brief that summarizes cost impacts to consumers. So that will look at premiums, out-of-pocket costs, and some of those other impacts. We thought that initially we were thinking we would ground the conversation leading up to the initial cost growth target public hearing in those 2013 to 19 trends. The more we've worked on the data, the more we thought about this, we think grounding in the cost impacts to consumers is the right place to start. So we are putting that into the queue. Thanks. And Michelle, we're showing the presenter view, not the full slides. Thank you. Okay. All right. I am on slide 9. Okay, it's a holiday week. It's fine. Everything's fine. So we wanted to just clarify that we do intend to publish state level and market level trends for calendar years 18, 19, and 20 using the initial data submissions that are coming in, but only after we have finished the validation. So we are not planning on publishing payer level or provider organization level data out of this initial data submission. That phases in next year, but we are working towards that. And so at some point we will have the 2013 to 2019 cost trends from our all payer all claims data, and then we'll have the state and market level trends for 18, 19, and 20 from this initial data submission, and we'll be able to talk about both of those together. So all of this is analysis and validation in progress. And next slide, just to share a little bit about the timeline, wrapping up this year and going into next year. As I mentioned, we're putting that consumer impact brief to the front of the line. Then we are working on that cost trends data brief leading into our initial public hearing in January, and I'll share more about that in a minute. And then we are also planning on a couple more reports throughout the year before we get into our regular cycle of the annual cost growth hearing, which will be in Q4 of next year. So sometime late next year, we'll have our second public hearing. I just blew through a lot of that and we had the slide confusion. So any questions about the reports or the timing before I keep going?
Thoughts, anyone? Okay, let's keep going, Sarah.
Great, thank you for your patience. So for the initial public hearing, we've talked about this over the last couple of meetings. We do have a small working group with some committee members and some Oregon Health Policy Board members. Our goal is to hold the initial public hearing before the February 2022 legislative session. We agreed that we would do a virtual meeting, that it would be 2 consecutive days for shorter periods of time each day rather than a full day virtually. That's hard. We had previously said it would be the week of January 17th or 24th. About half an hour ago, we landed on dates. So hot off the press, I can ask you all to save the date for Monday, January 24th and Tuesday, January 25th. So 9 to noon on the first day and 9 to 11 on the second day. We'll send this out in email and get our website updated, but we just landed on the dates seriously half an hour ago. So that is our plan for the initial public hearing. We'll be bringing that planning group back together in December to continue to work on the agenda, and that will continue to develop over the next couple of weeks. All right, and then advisory committee recruitment. So as we know, we are standing up our successor committee, the Cost Growth Target Advisory Committee. We originally opened recruitment for that in mid-September. We received 32 applications by mid-October, and we looked at that slate of applications and we thought about presenting it to the policy board and seating members of the new committee. And we determined that the applicant pool is just not representative on a couple of dimensions. We didn't feel like we had the right balance of industry and non-industry voices. We didn't feel like we had the right geographic or demographic representation. So we checked in with the policy board in early November and got their blessing to continue recruitment to try to balance out that slate of applicants before appointing the advisory committee. So we are continuing that. We did a lot of outreach this month to additional groups, well-connected folks who might know community members or consumer representatives, consumer advocates, and can help get the word out. And we are hoping to see a boost in our applicant pool, and we'll be revisiting this with the policy board in December. If you're curious, we did share what the original applicant pool looked like with the policy board in November, and the summary presentation is linked on the slide here if anyone wants to look. I will say it was really validating to see that so many of you all applied to continue. We had, I want to say it was 50% of current committee members applied to continue on the advisory committee, and that was great to see your commitment to this work and the thread of continuity, which we know that we want. We do want some members to continue to maintain that history and that context.
Good.
And again,
Sarah, is there anything this group could be doing to help you find new recruits? Yeah.
Yes, and I didn't even plant you to say that, Jack. Thank you.
Yeah.
If any of you have connections, folks that provide some more of that geographic and non-industry representation in particular, we're really looking for folks who can speak to the consumer impact side. So this is a little bit of a fine line where we're not necessarily looking for a consumer as in an Oregon Health Plan member themselves, although that would be fine as well. but folks who might have experience helping folks advocate for costs, or who have been working with folks who are experiencing cost struggles. So medical debt and bankruptcy, brokers. Shannon, we've reached out to the brokers pretty broadly, but if you know anybody, definitely put in a good word. But yeah, we would love help boosting the recruitment in the last couple weeks. Any comments or questions on committee recruitment? Okay, so the Value-Based Payment Compact Work Group, this is one of our other bodies of work that has spun off of the committee and is continuing to progress. So just real briefly, I'm going to share the update on the slide and then ask Ken to provide a little more detail.
Good.
So the work group is working on its roadmap to implementation. The goal is that that will be complete by February. And the group is focusing a lot on challenges around provider participation, or challenges around agreeing to the compact and meeting these targets. So lack of will to change, provider fear of financial loss, small patient populations, and multiple payment models are all issues that have been identified as challenges. And the work group is working on strategies to overcome those challenges. And I'm not sure, Ken, can you share a little bit more and maybe how that's all going to come together in the roadmap?
Sure. So the, a lot of the work, I think, to this point has been focused on two areas that probably both lead to the roadmap. One, we brought on additional committee members over the summer. And so there was a fair amount of time getting them up to speed. And then we've been really working through a prioritization process of what are our areas of focus that are consistent with our charge and that have some likelihood of having some impact. And then that then again should then funnel into the roadmap, which I think the plan is to get that done early in the year. So by February. Originally it was hoped that would happen a little sooner. But I think with all the new committee members coming on and the group really going through a pretty intensive prioritization process, it made sense to slow that down a little bit. So that's more or less where the group is at.
Any questions, comments, or reflections? Probably for Ken, not me, on the VBP Compact Group.
Yeah, Ken, thank you for your leadership on this, by the way. We so appreciate it. Is it your sense that we might develop some models or some thinking that would help in our 2023 effort? Is that kind of the goal at this point? Because 2022 is sort of behind us almost.
Yeah, I mean, I don't know that we're necessarily working on, this year versus that year. There is a fair amount of discussion and debate in the group about whether developing models is the compact's role, whether facilitating that in other environments is the compact's role. So there's still some work to be done in terms of really nailing down what's the role of the compact versus others. And there's a sort of an open question around how much ability do we have to really implement things? Can we influence them? Can we work with others to develop some common approaches? But that's still an item I think that's being discussed.
Okay.
I will say one other thing that the compact has had to sort through, and we sort of toggle between the work of value-based payment and really the work of this group. And we're still getting some clarity on that, I think, in terms of really focusing on the value-based payment to the cost growth impact. But sometimes we come at it a little bit from the other end, and I think we've been just working through that. I think there's been a little bit of confusion over that.
Gotcha. All right. Well, again, thank you for all your help on this effort. Okay. Any other questions on this one for Sarah or Ken?
Okay, Jack, I think the next update or topic is yours.
Yeah, this was, I kind of asked for this topic. And again, my only interest here is to get a general idea. I'm not looking for specific contractual terms here, but I was curious to know from the market, since I'm not in the market, how the provider contracting was shaping up for 2022. I'm particularly interested in knowing informally, have we seen some advances towards some value-based arrangements? Has the provider community, generally speaking, been seeking rate increases in the commercial market that are supportive of a 3.4% total cost of care inflation rate? So I was just curious to know what the early indication, actually it's not so early. I mean, here we are, it's late, it's almost Thanksgiving. And I imagine that a lot of the negotiations between payers and providers for 2022 are completed, but they're not always completed until sometimes after the fact. So I just wanted to open it up and see if anybody wanted to volunteer a reflection on how it seems to be shaping up for next year. Any takers? Yeah, Craig, looks like Craig has a comment. Good. The actuary, love that.
Thanks, Jack. Yeah, I would say that we have been moving down the path of value-based care for a while at MODA, but it definitely would say it put some wind in our sails to have the value-based contract there. I think it makes it a little more real and help those conversations. And I'd also say that the types of increases we're seeing seem to be informed somewhat by the 3.4% target out there. So it seems to be in the consciousness.
Good.
Just a couple high level observations.
Good. Well, that's encouraging. It looks like, Ken, you have a comment?
It'd be pretty similar to what Craig just said. I think we've definitely seen a pickup in, well, certainly in the depth of the discussions. There's good movement. We'll have more value-based payment arrangements in place in 22 than we do in 21. I don't have that quantified yet. But there's been, I think, some decent progress.
Wonderful. That's good to hear. It looks like, John, you have a comment?
Yeah, I think that I'm getting lots of questions about this. So I think it's changing the conversation. And I think there's sort of some attempts to kind of really understand what's happening there. I think I heard some concerns or gripes that brokers who are working on the exchange or the independent individual market or small group market were asking for, or we're out negotiating with not with providers, but negotiating for I'm going to get my market wrong. Anyway, negotiating for something higher than 3.4%. And so they were coming back to providers and saying, we want 3.4%, but going out and asking consumers to pay for rate increases that were above 3.4%. That's just all anecdotal, but this is what I heard. Okay,
good. Thank you, John. Angela, it looks like you have a thought there, please.
Yeah, Jack, I will say that our experience is very similar. Most providers are understanding the 3.4 and are negotiating in good faith. There are a few outliers, and what I find is that they are typically uninformed. And so there's still some provider education that needs to take place. I wouldn't say it's holistically and across the market, obviously, but I do think that there's some more education for them to fully understand.
Gotcha. Okay, good. Well, that's all encouraging. Any other thoughts? Anybody on the consumer side? Felicia, you're usually in the know on these things. How are you looking for your group next year?
Yeah, I'm happy to talk about that. I also do want to jump back. I had a question for Ken too on the value-based payment side, but I will say that 3.4% for our membership, frankly, and I understand that it's a collective purchasing group, so we have a lot more influence, has been good. And it's been able for us to sort of say, both in our contract negotiations, but also in the health plan that we purchase, that we won't take a rate increase greater than that. Like we just say no. So that's been very helpful, actually, both for our staff plan as well as our trust plan. So I think right away we can see like we will have actual people will have a lower cost of healthcare in this next coming 2 years because we were able to sort of just push back and say no. And so that's huge, especially for the low income workers that we represent. 3.4% increase is already high enough for them.
Yeah. Oh, yeah.
And they didn't get that in wage increases. So it's a really good sort of concrete example for us of, saving somebody a couple $100 a month, actually. And then I think that my question to Ken actually was back on the value-based payment, which I actually think aligns well with this, is as you guys are having your discussions and rolling these out on the insurer side and discussions with providers, are you aligned in what a VBA looks like within your own systems? Or are you kind of trying out a bunch of different things?
Well, we're using the land framework, right, as the way to really talk about what the models are at a high level. We're not at a point at all where we're talking about whether we're using, the same risk sharing arrangements or the same budget models or anything like that. And we probably need a protected environment to do some of that. But at this point, it's not been focused at that level. It's really been using the land framework to create the commonality.
Any other comments around the provider payer negotiations for next year?
Jack,
This is Brian. Kelly.
Yeah, Brian, sure, please.
We really haven't seen any advances in value-based arrangements. There was some clunky tries, but I just because I hear everybody being real be negative, I think there's hope for the future, but I can say renewing 2022, we're not seeing any. So we're a specialty group, so somewhat unique. The payers may be doing that with other specialties or with the systems themselves, but just speaking for an independent medical group just out there, we're not seeing that. 3.4 also isn't reflective of the cost that we're experiencing. At least within healthcare, raises and increased wage are more than 0.4%. So just have to go on record on that.
Yeah, well, general inflation is certainly up over the last several months. That's fair to say. But I guess I would just hope that the people that are on this committee are going to try to lead by example and try to, do whatever you can to kind of live within a target growth of 3.4, whether that's by taking less on a fee-for-service contract or leaning heavily into value-based, whatever it is. It would be great to know that our committee is leading that and leaning into that effort, is all I can say. But I appreciate the comment. Thank you, Brian. It looked like Mary Beth, you've got a comment, and then it looks like maybe John has another one to share. So let's go to Mary Beth first.
Yeah, I just don't want to be duplicative of what Felicia said, but I would echo her comments that a couple $100 is really big for consumers, and any savings that we can pass along by lowering those costs are really important. So I'm really excited to see the 3.4% come into effect. Yeah,
good. John, comment? Yeah.
Just I think one note for the committee, since I'm be stepping off, but I think that this is something that the group is going to have to deal with in the future. I think these rate increases and watching the market are going to be important, and I want to come back and say a little bit of this in our reflection. But I think the other thing to keep in mind is sort of what types of investments and kind of building and high intensity types of things are going in place out there. And so OHSU is going through, it's sort of planning out a pretty large inpatient new set of buildings that may be justified because I think we've seen with COVID a lot of lack of capacity, but there's some balance there. But I think anytime you see a large investment there, there's going to be some attempt to recoup that, even if you don't see it through rate increases, kind of in the near term, 2 to 3 year market change. It's something that's going to play out, and I think something that that the committee is going to have to grapple with in the long run. And so I just want to kind of, as a parting comment, just remind people that it's not just the rates, but also sort of like what services, what's the mix of services, and how are they being used, and what's the the mix of technologies. And, I think the kind of evidence is that prices matter, but really kind of one of the biggest drivers on this is use of new technologies and capital intensive types of things. And so that we can anticipate that some of that's going to be coming out after COVID too.
Yeah, that's a good point. Thank you.
Hey,
Other
Jack,
comments?
it's William.
Oh yeah,
I
William,
haven't
please.
figured out how to get my hand up here, but let's not forget utilization here. We've gone 2 years with which, we all know there's a lot of pent up demand out there. We're seeing it in our hospitals today. And so to suggest, price is one thing, but utilization is going to be another thing we're going to have to deal with as we're moving along. We're just seeing, again, people have put off healthcare for almost 2 years, some people, and some people can't get in for their surgeries. So at some point, we're going to have to understand that impact as well on the 3.4.
Yeah, absolutely right. Yep. Thank you. Couldn't agree more. Good. Okay. Well, that's good. That was a good dialogue. Any other comments? I don't see any other hands up, but I don't see everybody. Sarah, is there anybody who's trying to get in and make a comment that I can't see?
I don't see any other hands.
All right. Well, thank you for that update, and we'll hope for the best outcome we can achieve going into 2022. Okay. What's our next topic, Sarah?
I have one more update. It was just going to preview some of the milestones for 2022 as we look forward. So just a couple of high level things in addition to the specific reports I already talked about. We do intend to hold that initial public hearing in January. I shared the dates. We do intend to launch the new advisory committee in Q1. Later in Q2, we will publish the data submission template and guidance for all of our data submitters. That will be updated every year. So there are some things we'll revisit and push out. We'll also spend some time next year, Q2, Q3, developing the accountability processes. So we need to actually operationalize your recommendations for the performance improvement plans and the financial penalties. There will also be a rulemaking process and a RAC, Rules Advisory Committee, for all of that accountability work. So that will be happening next year. The 2021 data submission will be due in Q3, and then we'll get onto that annual cycle for public hearings in Q4. So just a couple of the high level things that will be happening over the next year. The biggest, most developmental piece will be the accountability work. And I think those are all of my updates.
Okay, very nice. Thank you. Are there any questions for Sarah regarding kind of our current status and updates and what we're looking at in the future? Any comments, questions? No, okay. All right. Thank you very much for that. So moving on, we thought it would be very helpful to ask Michael Baylett, who has been with us from the beginning, to kind of do a review of where we've come over the last couple of years and how our work has been informed or is informing other efforts around the country, and just to kind of give us some frank reflections on what we've achieved or not over the last couple of years. So Michael, it's all yours.
Thank you, Jack, and hi, everyone. So I have been with you all on this full journey. Actually, I started even before, about 6 months before you had your first meeting. That first meeting was almost exactly 2 years ago, almost to the date. And when we started, only Massachusetts had any experience with a cost growth target, and Delaware and Rhode Island had just started their programs. They were in the first year. I will say that generally the focus on affordability was just emerging around the country. It's much more heightened right now. So things were quite a bit different 2 years ago when we started this journey. The next slide depicts, in terms of a map of the US, where there were cost growth targets 2 years ago, just little slivers of green on the East Coast. That was it. And now, 2 years later, you can see there's been a lot of spread, and particularly, right along the West Coast, with, I would say, California likely to join the party coming out of this next coming legislative session. And so, pretty significant expansion, and I'm pretty sure that there will be other states that will follow. But big growth in attention and participation in cost growth target activity in a pretty short time period. So this is all in the context of broader conversations about affordability. And these are just a few examples of state efforts that are focused on affordability, especially in the commercial or employer-sponsored insurance market. Some of these are states with cost growth targets, but not all of them are. And you can just see these new offices, advisory groups, task forces, all looking at the problem of affordability, which we've seen in our data and other states have seen in their data, where you've got especially commercial healthcare spending growing at least twice the rate that wages are growing year after year after year. And that's both for premiums and even more so for out-of-pocket spending, where the growth has been particularly dramatic. So affordability is a key concept now. I will note that in my work across the country, it's interesting, the big national funders are now all focused on affordability. Robert Wood Johnson Foundation's focused on it, Commonwealth Fund, Arnold Ventures, just lots of attention here. So the whole tenor of national conversation and health policy has changed. So I want to review now what was your charge and what you've accomplished, because you've accomplished a lot over the 2 years, especially in the first year, which was a really intensive year. So you were charged both by Senate Bill 889 and by Governor Brown in a memo that she sent to you to do 13 things. And this is just the order in which they appear. Certainly not a chronological order. You need to recommend a governance structure for the target program, which you did. You need to recommend a methodology for establishing the cost growth target, including the economic indicators. We spent a lot of time on this, lots of debate, I will say lots of negotiation on it. But you reached agreement on that and on the frequency and manner with which the target should be reevaluated. You identified, I would say with a lot of support from Sarah and OHA staff, the data that providers and payers, really payers in the end, needed to report. We talked about technical assistance and support, and there wasn't a really strong feeling about the need for it at the outset. But that might be because when we had the conversation, we hadn't really adopted specific strategies that we wanted to advance to assure cost growth target attainment. Obviously, we're working on that now with value-based payment as a first area of focus. And I think that probably your successor advisory committee is going to come back to technical assistance and support once there are some concrete ideas about strategies to adopt to help achieve the target. But you didn't go so far there on number 5 or on the next slide and number 6. Which if we could advance, thank you, which is opportunities to leverage public and private resources, because again, you didn't have strong recommendations on technical assistance and support. You did talk about measuring quality of care and aligning it with the HPQMC's work, and ultimately supported a measure set that Sarah brought to you. As you know from the report you heard earlier, the VBP body that's going on through the OHLC partnership is working on payment models. There's still a fair amount of work to do there, but that work is well underway. In terms of identifying unjustified variation, I think that work wound up being embedded in the data analyses that OHA is just beginning to develop, and as Sarah said, will begin to report shortly. So I think pretty much you delegated that to the cost driver analysis that OHA will be performing. In terms of payers and providers to report in your recommendations report from a year ago, you will support a methodology for which payers and which providers. So you check that off your list. Then the last three things in the last slide, you made recommendations on accountability and enforcement. And I will say really forged new ground there when you did so. Next slide, please. And then number 12, you made recommendations regarding how data should be reported after it's been collected. And Sarah just talked about plans for reporting the data. And then finally, you, with OHA, established a timeline. So you had 13 charges and you addressed them all. It was a lot of work to do. Again, it was heavily front loaded. Almost all of this work we did last calendar year. And it was an intensive year of work. For those of you who just joined this year, you missed out on a lot of fun, but it was quite a productive year. The work that we did, next slide, please, was organized around 5 work streams. Maybe some of you will recognize these graphics. And so I want to review the outputs that we had for these 5 different work streams that, again, came from the legislative charge and the governor's directive. Next slide, please. So the cost growth target speaks for itself, methodology and governance. For quality, we were trying to infuse in both quality and equity, which is a relatively still recent OHA top priority. The data use strategy was about how to leverage APAC data. APAC is the state's all payer claims database and other data sources so that we can understand why performance might be above or below the cost growth target or vary from market to market, because the data that the payers submitted actually just recently is at a fairly summary aggregate level. And if we really want to understand what's going on underneath the proverbial hood, we have to have a supplemental strategy, and that's the data use strategy. Transparency and accountability was a huge focus for you, particularly last fall. And then taking action, what we meant by that was how to take specific actions to lower healthcare spending growth so that the target is achieved. Because if all we do is set a target and then report on whether we met it or not, we're probably not going to be successful. We're probably going to have to buttress, and you all agree with it, buttress the target with specific targeted actions to support its attainment. So the next slide has the output from these work streams. For the cost growth target, you set targets 3.4% for 5 years and then 3% for the next 5 years, measuring at state, market, insurer, and large provider organization levels. For quality and equity, you supported public reporting of a subset of quality measures from the HPQMC and a focus on inequities, as well as measuring unintended consequences that could result from the cost growth target. For the data use strategy, you adopted goals and principles to guide future OHA analyses and anticipating transparent reporting in the future, which sounds like it's coming quite soon. Transparency and accountability, you adopted a 2-pronged approach. The first, performance improvement plans, or PIPs, would be the first accountability step for what we called unjustified high cost growth, with meaningful or substantive financial incentives second. And you also supported both public reporting and hearings, and you just heard about the plan for hearings. And then finally, for taking action, you agreed upon a process and criteria for recommending cost growth mitigation strategies. I think those are going to be a gift that you're going to leave for the future advisory committee, that they will be using them more than you did, but you did use them to adopt a value-based payment compact that led to the creation of Workgroup to accelerate VBP adoption. So a lot of output, and I think you should feel really good about all that you've accomplished. And again, most of this was accomplished in 1 year. So what I'd like to note now are some of the things that I found to be distinctive, because I've been involved with all the other states that are doing this work, and there are some ways in which your approach has been distinctive. So I thought this might be interesting to you. First, you have had at the table a full range of parties who have interest in the outcome of this process. This differs from some other states. In Massachusetts and Washington, they have what I'll call protected bodies. So provider organizations are not at the table. And the same is true of health insurers. They don't sit on an advisory body. Whoop, can we go back? Thank you. So they don't sit on an advisory body or steering committee or governance body. And so that's quite distinctive. And further, I want to say it's worked. And it's worked for reasons I'm going to explain subsequently. But in some other states, it would be very possible that having organizations that might consider themselves to be constrained by a cost growth target would lead to lots of conflict and opposition, and that did not happen at your table. And so you had both a more inclusive table and a more inclusive table that worked together really well. Two, I want to note that in contrast with most other states, the employer and consumer advocate voices at the table, some of whom are no longer at the table anymore, but those that were here last year were articulate. Their opinions were respected by the group, and they had a lot of impact in the conversation. In fact, I thought that your conversations last year when you were debating recommendations were the most balanced I've heard in any state. So something that was really impressive. And kudos to all the voices, not just the employer and consumer advocate voices, but to all the voices for making that happen. Next slide, please. What I found really impressive was that all the committee members accepted the problem of affordability for Oregonians and the need to address it and be accountable to it. In some other states, I've heard health systems argue against slowing healthcare spending growth and have denied responsibility for affordability. And that didn't happen here. There was total buy-in that that affordability was a common good for Oregonians, and that all parties needed to own it, and that everyone needed to collaborate in finding a way to achieve it, as difficult as it is. So that just really impressed me, how that happened. And again, not that it doesn't happen anyplace else, but I have seen in some other instances where it didn't happen. And then finally, conversation was always respectful, even when there were important differences of opinion, and there was a willingness to compromise during difficult conversations. So these were all really impressive aspects of your process and distinctive elements of your structure. And I want to call that out because you don't make progress with really good process, and you had really good process. Last, I want to highlight where you broke some new ground relative to work across the country. You're adding quality measures and a focus on health equity was a first as a complement to a cost growth target. The introduction of statistical testing to assure confidence in finding of cost growth target achievement was also new, had never been done before. Your introduction of financial accountability for exceeding the cost growth target repeatedly and without justification, first time ever that's happened in the US. And then finally, you're establishing a compact to accelerate adoption of VBP, value-based payment. That too was new. So a host of innovations. Now, of course, there still aren't that many states that have done this, but nonetheless, I think that these are still innovations and advances to be celebrated, and some of them are already being adopted in other states. So they are learning from you and from your innovation. So hopefully this is a little bit of a reflection on the journey that you have followed over the last couple of years, and some of what made this process special, in my opinion, and some of the innovations that you introduced to the nation in terms of how you approach this work.
Very thoughtful and very kind words. Thank you, Michael. We appreciate it. I know that there are some comments and questions. I have a couple myself, but let's go to Catherine has a comment, and then Ken.
Thank you, Michael. That was great to see that recap. It was a lot of work, and it was nice to have that recognized. Question about the East Coast, West Coast, and the sort of the adding on of the states as it goes. Is there an opportunity for maybe just the West Coast, but maybe the full amount of states to collaborate? We have a lot of cost focused, at the very local level provider, insurer, but there are some big things too. As we think about drug costs, data sharing, things like that. Has there been any talk about collaboration going forward amongst these states?
So the states right now are all participating in meetings with one another through the Peterson-Milbank program, which is providing support. In fact, we just a week ago, 2 weeks ago, I can't remember, I've forgotten.
Michael,
we had a 2-day meeting of all the states, and even Massachusetts was invited to join. So there was a lot of sharing. There hasn't been conversation yet, Catherine, about doing work in collaboration. I will note it's hard for states to collaborate across states, but I know that for you and for some others here, your market is multi-state, including some of these bordering states. And so it would actually be convenient for them to collaborate. Again, we haven't had that conversation yet, but it certainly is a possibility. If you have thoughts on where you think it would be helpful, I'd encourage you to share that with Sarah, and because I think that's an idea that certainly could be explored.
Great. Yeah, maybe that's something the next advisory group could also take up. So thank you.
Yeah, I'll also note, by the way, Catherine, that the Peterson-Milbank program is planning on a regional meeting of the Western states in early 2022, a face-to-face meeting. And so if you've got any ideas you want to introduce for conversation, then there's an opportunity.
Great. Thank you, Michael.
Ken, before we get to you, I understand that we have Rachel, is it Rachel Scott, who's on the phone from Milbank? And I wonder, Rachel, this might be a time for you to weigh in with any comment or observation. And Ken, I know we'll get to you in a moment, please.
Well, thank you very much. Actually, I was looking forward to hearing other questions, but I'll continue to participate afterward. I just, first of all, I thought Michael gave an excellent summary, and to let you know how much we at Milbank also appreciate both the leadership that went into this, and the leadership being all of you. And I think that's one of the key themes, and Michael mentioned it a couple of times in his presentation. Also, as relates to coordination with the other states, part of that is about a learning community, and we continue to try to identify the opportunities to share that learning. We featured Sarah in a couple of discussions at our first virtual, unfortunately, annual meeting of the Peterson-Milbank states. But I am sure we will find additional opportunities to share your experience and your technical work with the other states. But there definitely is an opportunity, in my view, to share more broadly. But I would also just like to make one other point, which is not central to this group, but I think is in the background, and I think also quite important, which is while your focus on sustainable healthcare costs has accomplished all these things, and you've heard now about some of the early experience through the value-based compact, et cetera. But there's other things going on as well. The passing of the accountability legislation, the passing of the market oversight legislation, the continued focus on primary care spending and its connection to value-based payment. And these are all part of the overall universe of strategies that will be necessary to really make the most of this focus on healthcare cost growth and affordability. So I really want to join everyone who has said so far how much we appreciate the group that has done this work so far, our commitment to continue to support Oregon, but our intention to continue to share Oregon's experience with others and just how much we value it. And I could just tell you, we've heard from the other states how much they appreciate learning everything that you have done so far and the impact it has had on them. So I just thank you, and I will continue to listen to your comments and questions.
Yeah, that's lovely. Thank you for those kind words, Rachel. One quick, and then I know Ken has something to say. Do you and Michael believe there are any efforts going on at CMS right now in the federal government around managing total cost of care and the Medicare spend that we ought to be keeping our eyes on? Because a lot of innovation has come from CMS over the years, and I wondered if you were privy to anything that you believe this next iteration of our committee should be watching.
Well, as I think you all know, we do have a new CMMI director, and she recently, with the CMS administrator, issued a new strategic commitment for the Center for Medicare and Medicaid Innovation that, among other things, committed to essentially having all beneficiaries, Medicare and Medicaid, CHIP and insurance exchanges enrolled in some form of accountable care in the not too distant future. And so everything that then would stem from that, clearly that is a much more concrete goal than what we had heard before. And I think we're all hopeful that that will stimulate both more policy activity at the federal level and also stimulate more coordination across regional, state, regional, and local efforts toward that end. We also have had informal conversations with staff at CMMI who work on state models, and they are in fact interested in exploring possible opportunities to bring total cost of care models, global budgeting, other global payments, all those sort of broad concepts into some new partnerships with Medicare and with states. But I think if there's one last thing I would say about that, well, CMMI is a great driver for innovation. One of the messages we left CMMI with is we need regular Medicare and regular Medicaid, whatever those things mean, to also be innovating at the same time that the Innovation Center is innovating. And so for all of those things to really be aligned, because the scope of the Innovation Center can only be so big at any given point in time. And we need the broad program strategies to be fully aligned behind the goals that CMMI has laid out. So we're hopeful about the energy and direction that we have heard at this point, but it is still a pretty high level. And so we will continue. And I would urge all of you, as I think you know, they're now in listening sessions and other things where they're trying to get direct feedback from the front lines about how to go about implementing these strategies.
Great. That's helpful to know. Good. Ken, you have a comment, please.
You bet. Michael and Rachel, thank you for your comments. Michael, one thing I would add to your list, and I'm not just buttering you up, but I would add this to the list that really I think made the discussions meaningful. I've served on a number of these committees over the years, and sometimes stuff comes in fully baked, and the job of the committee is basically to rubber stamp, or at least that's the way it feels, and move it on. And I thought between Sarah and Jeremy and Michael and others, there was great work that was done between meetings to do some background work and get things framed for discussion. And then we really were truly able to debate that. And sometimes you have to say there were guardrails, right? There needed to be financial penalties as an example. And we had to work within those guardrails, but it wasn't like everything came in fully baked. It really felt like our discussions were important and meaningful. And I thought that was helpful.
Yeah, that's a great comment, and I echo it 1,000 times. Thank you both. Yep, thank you, Ken. Other comments, other questions for Michael? I mean, I have one, Michael. I guess my question would be, is there anything that we didn't do that you feel we could have done? Are we missing anything and that we ought to be considering? That's number one. And then secondly, I wanted to ask you, based on your work in Massachusetts, which is, several years ahead of us, is there anything the state is doing around monitoring, implementing, achieving? They're in that mode now, that we ought to keep our eye open here and be open to thinking about. That makes sense. You're on mute, Michael. Wow, Michael doesn't know how to get off of mute. This is a first. All right, well, is everybody else on mute? Sarah, can you talk?
I think I can talk.
Okay.
I could say a couple of things while Michael is pushing buttons there.
Okay.
So I think everyone knows Massachusetts reported that their cost growth was exceeded their target. One of the key differences is that the Health Policy Commission was only given a limited set of tools to more directly intervene. This cost growth pattern has caused them to both examine if they can make better use of the tools that they have, but also essentially to tell the governor and the legislature that they have to consider stronger measures. And that will clearly be a focus coming into their legislative session next year. There are several different proposals that have been offered up, and I'm sure there's going to be vigorous discussion. But Michael, now that you're off mute, you can jump in here.
Yeah, please, Michael.
Yeah. So just to clarify, while I talk to Massachusetts all the time, I actually don't work with them per se.
Oh, okay.
But not so much from Massachusetts, but I would say in general, if there is discussion across the country on affordability, it's about price.
Price per unit of service, or what do you mean, price?
Yeah, price per unit of service.
Yeah.
And price as a cost driver, primarily for hospital services and for drugs. And now you've adopted a much stronger accountability mechanism for other states, but there are some states that do not have a strong accountability mechanisms that are thinking, what should we be doing about price? Because price is what, especially in the commercial market, is what's driving the affordability problem. And of course, and I heard this just this morning from a CEO of a big hospital system in another state. He said, well, commercial prices are a safety valve because we can't do anything about Medicaid and Medicare.
Right.
But I would say that that price is getting a lot of attention in other states, and it will be interesting to see what approaches states take.
Are you aware of any state that is considering or is implementing a commercial fee schedule for provider services?
Yeah, so most of the discussion is about creating limits on price growth and on high outlier prices, but not creating fee schedules. I don't think we're going back to the 1970s when that was in fashion in a bunch of states. But the state that got out first on this is Rhode Island, which put in caps on how much commercial insurers could increase hospital prices on an annual basis. And this morning at a public meeting, they announced that they plan on doing the same thing with professional services.
Gotcha. Interesting.
And so it doesn't actually address disparities in price.
Right.
And they're not doing anything on sort of high outlier prices, although, there's some discussion about that in some other states.
Right.
It's just on how much they can grow a year.
Yeah, gotcha. Okay, interesting. All right. Other comments, folks? Anybody have any other thoughts
Jack,
around? Yes.
Jack, do we
please.
want to transition to the reflections? It feels like this is a really natural
Yeah,
segue.
it does. It does feel like we're into reflection mode. So why don't we just ease on into reflection? So yes, let's do that. I have some thoughts, but I think I'm going to wait till the end. So we don't really have any particular method for this.
I think Jeremy was going to kick us off, and then we'll.
Oh, beautiful. Okay, that's wonderful. Is Jeremy with us now?
I am.
Yeah. Oh, magnificent. Jeremy, oh my gosh, I'm so glad to see that you're alive. What's on your mind?
I've been battling a cold, so I'm also glad to be alive.
Right. Good.
Thanks, Jack. And sorry, I was about a half hour late. I had a meeting with a legislator that couldn't be moved, but I only caught the tail end of Michael's presentation here, but I think it is a really, I think it's a really impressive amount of work that's happened over the last couple of years. And I was thinking about, this actually goes all the way back to 2017. And sorry if you had said this, Michael, but I mean, this work really began with a task force, legislative task force back in 2017. And that I was on, a number of folks from this group were on, and that started as a hospital, price setting task force. And after looking at the Maryland model and deciding that wasn't right for Oregon, it wasn't really clear whether the group was going to continue on or just sort of say, okay, we looked at that and we're done. And I think kudos to folks at that time, Craig, others were on that. We kept pushing forward and saying, okay, we got to do something for cost. There's got to be some solution out there we can move forward. So it's pretty amazing, 4 years of work later. I was doing a presentation last week for Women in Healthcare panel, and was sort of bragging about, being lucky to be in a state where we're always on the cutting edge of health policy. And was asked if there's other states that are sort of the envy of Oregon. And I was a little stumped, and maybe it's hubris, but said not really. It feels like there are this group of states that we have all of the same key ingredients, and we kind of keep pushing each other. But total cost of care and cost growth targets is clearly kind of a key pillar, I think, for the next wave of reform among a number of states. And you saw that in the map earlier. And I think that's just something to be really proud of. I think there's a lot of states that have not seen their role in health reform and transformation be beyond much of running a Medicaid program. And we've continued to be a state that's trying to figure out how to innovate and serve all Oregonians and get costs under control statewide, not just within our Medicaid program. I think to Rachel's point around conversations with the federal government, we've had a couple of conversations. We've been making rounds with the new administration. I've had a couple of really promising conversations with leadership at CMMI and others in the administration. And I think there's a big desire for them to go from a whole bunch of sort of small pilots to something that really is bigger and is multi-payer and is really aligned with total cost of care, kind of global budget work. So, I'm not sure where that's going to go exactly, but I know in talking with them that they have said the same thing that I just said, that there's a couple of states that they see that really have the key ingredients for the next wave of health reform, and a huge push towards multi-payer alignment and total cost of care, and really moving towards paying the health system in a new innovative way that really gets population health, is population health focused and is health equity focused. So I think we're really excited. And I think, several years ago, I thought about this program really being a key pillar for our next wave of health reform, and had been saying that, but I think we're seeing that and seeing that it's aligned with this administration as well, and excited to keep you all apprised as those conversations continue. I guess I just say, I just think kudos to this group for sticking with it for 2 years through a pandemic. I think it would have been really easy to just walk away last summer. I know everybody has been completely stressed and tapped. And I think it's just an amazing commitment that everybody stuck with it and said, we know that there's going to be another side of the pandemic. It's a ways away, but we've got to get costs under control one way or another. I think the task ahead of us is going to be maintaining the momentum going forward. And while we've got several years before the stronger accountability mechanism kicks in, I feel like I've been telling folks, I don't think we have that long. I don't think the legislature or others are going to wait till 2026 for us to, as a state, collectively figure out how to get costs under control. And I just think a big lesson from CCOs is just maintaining that, I think leadership momentum statewide. And so I know as folks are starting to cycle off, want to be able to just stay really closely engaged with you all and make sure that we keep this front and center as a key part of our next wave of reform in the state. So thank you all for the commitment over the last couple of years. It's been incredible working with you.
Oh, I was going to say, Jeremy, thank you so much for your comments and your leadership. We've so appreciated it. Maybe I'd ask Kevin as our co-chair. You've been so awesome, Kevin. Any comments you'd like to make to kind of kick us off here a little bit?
Yeah, great. Thanks so much, Jack. And thank you, everybody. I've had my camera off just because my Wi-Fi in my house works better if my camera is off, but very happy to share some reflections. First one that comes to mind is just the complexity of healthcare finances. And just when we think that we have it all figured out, there's another confounder, another variable that we haven't thought of. And so I think that's very mindful moving forward is that it's very, very complex. But I've been really proud of Oregon having that additional focus on health equity, and really happy to hear from Michael that we're one of the forerunners in doing that. I think it's one of the things that I'm most proud about of being an Oregonian is that we're willing to go there. Policy work is difficult. But then the next challenge and hurdle upon all of us will be the operationalizing of any policies, and putting into practice of the policy that is developed is extremely difficult moving onward. And we just have to be very mindful of that it might seem very easy to us because we were the ones that came up with the policy, but then the downstream entities of having to work within the confines of a public health policy like this can be challenging. And then I would say that it's going to be really important moving forward to be mindful of the physician and clinician voice in all of this. And people have commented over the last couple of years that we need to get more physicians, clinicians to the table. And while I completely agree with that request, it's also going to take away physicians and clinicians from patient care. And we already have issues with access. So my challenge and my request to those systems and plans that employ physicians and clinicians is to really ensure you're reaching out and hearing from the physicians within your organization so that they are willing to come to the table with solutions and at times coming to the table with solutions that isn't going to be taking them away from the patient care activities that they're responsible for. So with that, it's been a real honor serving as a co-chair, and thank you, Jack, for being such a great chair over these last couple of years. I've been on this journey since 2017 as well, so it's really exciting to kind of see us come full circle and where we're going to take this in the future. So thank you.
Thank you, Kevin, for those kind thoughts. Very nice. Thank you for everything. Okay, now I know that John McConnell had something he was going to say. So John, I can't see you, but I know you're there.
Yeah.
And, I know you wanted to share a couple of thoughts, so please do.
Sure, I'll share a thank you for everybody. I really enjoyed getting to know people and having some serious conversations about a serious issue and serious project. Really find that to be kind of a highlight of the work that I get to do. And so thank everybody for that. I guess I have two thoughts or recommendations or two things I want to drive home, and this is sort of thinking out into the future. The first one, I'll just sort of reiterate that, one of the big drivers of long-term cost growth is technologies and introductions of new things, and technology can be broadly defined. It could be new devices, new procedures, new tests, new drugs, new buildings, things like that. My experience so far is, and kind of the discussion often is around kind of next year's cost growth and what's happening with rates and things like that. But at the same time, and again, I don't want to, I sort of want to be neutral here. I think there's reasons to celebrate what OHSU is doing in its new building, but also reasons for this group to be kind of look at it with a careful eye. A lot of celebration of this kind of plan for increasing hospital capacity and inpatient capacity. Again, that may be warranted, but I think this is going to be, these issues are going to be a challenge for the group going forward, and they're beyond price. And these are the reasons that that spending on Medicare goes up, even though Medicare doesn't have the same price issues in the commercial market. So I just want to call that out. I think that this is going to be a dynamic strategy that the group has to adopt, and how you think about responding to those types of things beyond just price, and they're connected to utilization, as somebody else mentioned. That'll be important. And so just keeping in mind this sort of underneath price, there's going to be introduction of other things, and what those mean for long-term cost growth will be important. So that's point number one. I think the second one is, really thinking broadly about what prices mean for everybody, especially for people who are kind of perhaps below median wages. I guess I'm sort of haunted by this research that's come out in the last 2 or 3 years. I think about it every day, which shows that in the U.S. mortality is rising for people who don't have a bachelor's degree. So people with education with a bachelor's degree or less, on average, the mortality is going up, and that hasn't happened before. And so we, as health people in healthcare, we should be pushing for mortality to be going down, not going up. There's kind of a reasonable story to say that at least part of that increase in mortality comes from higher healthcare prices, which dampen wages, which sort of lead to kind of lowered expectations and these so-called deaths of despair. And I think that hasn't really been decoupled. That sort of on the one hand, we're in healthcare, and we like to be glad that we're sort of doing the work of providing healthcare to people, but also at the same time, we've been kind of responsible for some of the prices that have gone on. That hasn't been there's no specific intention there, but prices have gone up, and we've all sort of kind of let that happen. And I'd like there to be a kind of recognition that those prices directly do affect health, and that kind of by ignoring them for a while, that some in our state and across the country are really suffering from these high prices. So I think really linking this work of trying to control prices with the mission of improving health that's at every healthcare institution's front door, that will be an important part of the story going forward.
Great thoughts, great comments, John. Thank you very, very much. We've really appreciated your insights to this work. Thank you. Okay, other comments? Sarah, I don't see everybody, but perhaps you do. Yes, Mary Beth, please.
Hi, thanks. Yeah, I joined this committee relatively late, about I think June or July this year, but even so, I've been really excited to be a part of it and to see after the legislative session how a lot of the programs and committees that have come out of the legislative session, like the Healthcare Market Oversight Program and the Value-Based Payment Compact, have been incorporating this work. And so just to continue that as the advisory committee takes over and OHA continues to implement those programs.
Great, thank you very much. Others who want to weigh in? We have time, people. We have time. Yes, Catherine, please.
Thanks for the opportunity, Jack. I would only say for the second question for advice, it's a little bit bold to suggest that, since don't know what the future will bring, but because we don't, and because we really don't understand what's happening today relative to some of the changes, some of the things just talk about, as we think about more, just the whole mortality issue that was just raised and what that means for fentanyl and all those sorts of things that we keep asking why in our data collection, that we don't assume that we know why, but that we keep drilling down because I think we will find things that we can collectively and locally work on together, and it might surprise us.
Yeah, good. Thank you, Catherine. Yeah. Other comments, other thoughts that anybody wants to share, please. Oh, Andrew, great.
Thanks, Jack, and good afternoon again, everyone. Andrew Stolfi from DCBS. So just agree with everything that's been shared already, and just to build on and add to that, want to start by expressing my thanks to Sarah, who's done an amazing job leading us along this whole time, and as well to Jack and Kevin as our chair and vice chair, and getting us going and keeping us going. And Michael mentioned this earlier about the diversity of participation and perspectives in this group. And I, because of my role, get to participate in a lot of advisory committees and other groups. And I really appreciated all the different perspectives and kind of the Oregon way of doing things, how we brought everyone together here. And also just the openness and collaborative spirit that everyone brought to this group. It was really refreshing and great to see, despite even all the challenges of, I think, our first few meetings in person and getting moved to virtual because of COVID. We sure did accomplish a lot, and I appreciate that. Looking forward, as we transition, a couple of things that I'll want to keep reminding and really stress for the next group to work on is to keep up the communication and explanation of what we're doing. And some folks mentioned this earlier, that there's still some groups out there that don't quite fully know what's expected and what we're going to be looking at. And it's going to be up to us to help make sure that that's happening and that's going. Also, having lots of opportunities for public input. We do that at the meetings, but really making sure that the public has a good opportunity and venue to share with us how the work is going. And then finally, I'd say there's a lot of other things that are going on, a lot of other big projects and initiatives like work thinking and potentially developing a public option that will be really critical that the advisory committee is not only aware of, but discussing and contributing to as much as possible to make sure that the work not only doesn't overlap, but complements each other. So that, thank you again. Really enjoyed being on this group and look forward to the next step.
Andrew, thank you very much. And, given your role with healthcare payers in our state, you're going to be instrumental in helping us keep to this goal. And so we really appreciate that you were part of this and that you're invested in it and that you're leading the effort to live within this this growth rate. So thank you very much. William Olson, please, sir.
Thanks, Jack. And I'll just comment on the second one as we transition to the next phase of the work. Just again, this work is all based upon the allowed. So when we're tracking the cost to the 3.4, it's on the allowed. And so just let's not forget who we're serving here. So it's the patient who actually has to pay out of pocket. And let's not allow that to go up more than the 3.4 either, because again, I just worry about measuring at the allowed level. We're forgetting about what's out of pocket.
That is a great comment, William. Thank you. Spot on. Other comments? Well, maybe that's an open door for Felicia to say something. I know you're concerned about the people that are paying the allowed or the non-allowed. Any thoughts that you want to share with us to put you on the spot? And now I don't even see you.
I don't know where I am in your
There you are.
bubbles.
I see you. Any comments for the good of the good?
I want to really, I think I appreciate what William just said, and clearly I am entirely focused on that out-of-pocket cost for individuals and what that actually means. I think both to John's point and to William's point that having a system that works for the people that we're trying to sort of have a system for, frankly, I think is very critical. And I hope that as the committee continues, we'll keep that at the center of what we're trying to do. I also think, I think that there's been a lot of lessons learned, and I think we've all been through an incredibly difficult time together, and we'll continue to be going through a difficult time together. I feel like for the last, I think 18 months, each one of us has said, well, when this is over at some point on some Zoom call, and I think I want to recognize that the leap that people have taken, knowing that this isn't over and it will continue for a while, and especially the impact on health systems. I think we may see a return to sort of what is normal as far as like my life and other people's lives are concerned when it comes to COVID, but the impact that a pandemic has on health systems will last significantly longer, and what that looks like. So I also think that it's laid bare some of the challenges that we've seen. And I think to Michael's point earlier about the inclusion of quality and equity, and really keeping that at the focus as well in the center, and making sure that we're not driving changes they're going to hurt those two components. I think the committee has to keep our eyes on the prize, because it's easy to make cuts. It's harder to make strategic decisions that lower costs. And so we really have to, I think, focus on that as a state. And then I think I want to, I'll recognize that I'm not the most kind, gentlest person when it comes to criticizing health systems or insurance industry. And I probably won't ever change that about myself. But what I will say is I want to appreciate everybody for making space for that here, and then also making sure that we're all driving towards that shared and common goal. And I'll look forward to working with you all to do that in the future.
Thank you so much. And we thought, speaking as a previous payer and provider, was in both, I thought you were very respectful, Felicia, about your comments. And I thought you did a magnificent job representing working people in this state, which is who we're here to serve. So thank you very much. Other comments that people want to make before we get a public comment? Any thoughts anybody has that we haven't had a chance to hear from? Sarah, I don't see anybody. So, and are we missing anyone here yet?
No hands yet.
Okay.
Well, moment to get off mute if they want to.
Yeah.
We have a few minutes.
Well, all right. I think that's okay. I might just conclude by just saying how grateful I am for everybody's time and attention over the last couple of years. I want to say that I felt, to the point that Andrew made and Michael made earlier, that having worked in healthcare in Oregon for nearly about 30 years now, what I've learned about this state is that people are able to put their petty self-interest aside and collaborate for a greater good. And I've witnessed that over the years, and it takes great leadership and compassion to do that. And I think this committee did a terrific job. And I want to really thank everyone for essentially supporting efforts to, in many ways, change your business model. From doing, everything all the time to doing the most good for the most people at the least amount of cost. And that's really what we need. So thank you for that. I want to thank Michael, Baylett, and Megan for really helping us focus early on and understand what our charge was, and bringing a lot of informed ideas from outside of Oregon to help us. You got us off to a great start. and really helped us focus early on, Michael, and lead the way. So thank you for that. I want to thank Michelle Hatfield for all of your efforts behind the scene, Michelle. You kind of drove this for us, and you were terrific getting everything out when we needed it. So thank you for that. And please.
Thank
Am I
you.
missing? Oh, yeah, you said so. Okay, great. And by the way, don't be ashamed to show yourself sometime, Michelle. Oh, there you are. Okay, fantastic. Michelle, thank you for everything. We're truly. I want to thank Kevin for being a terrific co-chair, for always stepping in at the right time and helping us advance this work. Kevin, you have like 4 other jobs, so thank you for that. Jeremy, we couldn't have gotten here without your leadership and keeping us on track and bringing leadership thoughts from OHA. So terrific work, and thank you. And finally, to Sarah, who I don't think we could have gotten nearly where we did without you, Sarah Bartleman. So thank you for keeping helping me advance this, for always keeping me informed, for having a great sense of humor. And to me, you are the shining star of the Oregon Health Authority. And I don't know what you get paid, but my guess it's not enough. So up to your boss, give this woman a raise, man. She deserves it. She deserves it. Okay. So with that, I think we'll move into public comment. Is that right? Why don't we do that now? And I know that we had a written comment from a fellow. I don't know if we want to read that. People saw that. I don't know if we have to read it. We don't. Okay, that's a good thing. Not that it was a bad comment, but time is short. And then is there anybody else out there who would like to make a comment for us to hear? Please.
Nobody has signed up or indicated in the chat that they wish to give comment, but we can give folks a minute if anyone wants to just speak up.
Yeah, we have time. Doesn't sound like, well, it's it's his Thanksgiving week. I mean, people are probably preparing for their meal, got to eat as well as get healthcare. What else, Sarah? We've given this enough time for people to weigh in, whatever they want to say?
I don't think we have any public comment. I think we could kick it to Jeremy for the last word.
Okay, Jeremy, please, sir.
Just going to say thanks again, everybody, for the commitment and great work. And I think one final kudos to you, Jack. Thank you for being a great chair and for getting us through some difficult conversations, and hope everybody has a great, safe, happy holiday this week.
Yes, well said. Thank you, Jeremy. Blessings to everybody. Happy Thanksgiving. Don't be strangers. And let's all do what we can to keep up the good fight of controlling total cost of care and making it easier for people to live. Thank you all.
Thanks, everybody.
Thank you.